Sir, we can start actually, sir. We have started live streaming.
Sure. So, good evening, everyone. This is Tilak Gajendran. Yeah, this is more of an informal session which Karthik has invited me to tell you about my journey to, starting MyDocs pharmacy here in Hyderabad. Yeah, to start with, we'll divide it into two sessions. I'll talk about myself and my journey towards starting MyDocs here. And thing is why we should have a pharmacy like MyDocs in India. That's more important because for you as PharmD graduates and even as a pharmacist, it'll be really useful if you're looking at the changing, the paradigm shift of pharmacy profession in India. And also, if you have a passion for patient care, not only just in the hospitals, but also in a community pharmacy setting, that's where we generally tend to have more exposure to the patients than in a hospital. So nearly about, I would say, 65 to 70% of the people or customers has an interaction with the pharmacist, mainly in the community or retail setting, rather than in a hospital setting. Because hospital, they are either ill or they have a surgery, elective surgery. They may be more looked after by all other medical professionals, including the pharmacist, but it'll be more in the immediate context of getting them out of the hospital. That'll be the prime aim of the doctors as well as other healthcare professionals in the hospital scenario. Okay, so yeah, at the end, we may have a question and answer session if you have any questions for me. So let's look at my journey. So I did my Bachelor of Pharmacy from India in those days. I'm talking about 1995 to 1999. And during those times, we didn't have PharmD, neither in US. I don't know about US, but not in India, of course. And Australia doesn't have. I practiced my whole life there, like as a pharmacist in Australia, and Australia doesn't have PharmD now either. So I did my B Pharm from Chennai, from MJ Medical University, and after that I did work for AstraZeneca in the marketing for just 6 months. I was very much not using your knowledge, but more about how it works with marketing. To be frank, is to convince the doctors to write their medications from the company. So that really didn't. I was not really interested into that. After working for AstraZeneca, I thought my interest was in working in hospital or as a clinical pharmacist, and India didn't have much opportunities in those days. And also I wanted to explore the area of health informatics or pharmacy informatics, which was in the developing stage in those days. And it's still in a lot more development even now, as you say. And it has very good scope even now. But saying that, everywhere the saturation point is coming through. So it's very competitive at this stage. So yeah, after finishing my B Pharm, I worked for AstraZeneca for 6 months, and after that, I worked in regulatory affairs, drug regulatory in Orchid Healthcare, and there I learned a lot about filing of new drugs to the new markets and US FDA filings, and I did for Singapore, Hong Kong, and Malawi in South Africa. So and other countries as well. So we used to prepare dossiers from the company to export our products. So you may be aware of it because nowadays a lot of people are getting into the regulatory affairs. And as I said, my prime interest was in hospital or clinical pharmacy. So and health informatics or pharmacy informatics. I moved from that space. So I went to Australia in 2001. I basically went there for doing my higher degree, and I did join postgraduate diploma in IT in University of South Australia. And after that, it was very much of coding, and then I was not a very, we not like technical engineers, so it was not much into the coding area. So I moved on to this Masters in Health Information Management, or more of MIS, Management Information Systems, from University of Sydney. So I finished my Masters from there in Sydney, and I, being only child for my parents, I did plan to come back to India at that stage, and I really tried to get into a job of health informatics or pharmacy informatics in that space, but they said you really don't have a local experience in Australia as a pharmacist. So okay, so in that case, I looked at the opportunities available for pharmacists, and it was a huge demand for pharmacists those days. To be honest, there were only 200 pharmacists coming out from Australia every year at that time for the whole country. And imagine, of course, their population is not big. It's just about 2.5 crores is the population of Australia, but still there was a huge demand for pharmacists. So I thought, okay, I'll take up my APEC, what do you call right now as CAPS exam, stage 1 and stage 2. Those days it was called APEC exam, or Australian Pharmaceutical Examining Council. So I took up that exam, I cleared the stage 1, and after that I did my internship in Saul Pattinson Chemist in Northern Territory in Darwin. After finishing my internship, when I registered myself as pharmacist in in Australia, I came back to India for marriage, and unfortunately I couldn't go back straight away because my mom passed away. It was due to cancer that time. And then we went back, and I had a job when I landed in South Australia. As I said, those days the demand was high. You didn't even have an interview; you just got a job straight away as a manager in a hospital. So I used to manage a tertiary, not tertiary, it's a regional hospital, a place called Whyalla in South Australia, and I used to train the interns every year there for like Pharm candidates, the final year students and the third year students. I used to have about nearly 12 candidates, one for each month. And apart from that, I had 2 technicians working under me. And later on, it developed, and we had pharmacists as well in that hospital, an assistant pharmacist. So that's because there was huge workload. And after moving for 3 years, I was working as pharmacy manager there, managing the hospital pharmacy department, and some clinical pharmacy services as well. Later on, I really wanted to move into the clinical space. So we and myself and even my wife got graduated as pharmacists there at that point of time. And we moved to Queensland Health, which is in state of Queensland, northern part of Australia, northwestern, eastern part of Australia. And when I went there, like we both were appointed as clinical pharmacists there. So that was in the hospital pharmacy profession. What our profile in down south in Australia, as in Whyalla in South Australia. It was more about hospital pharmacy pharmacists, so it was more about dispensing pharmacists, less of a clinical pharmacist, very less ward rounds, but managing the inventory aspect and dispensing aspects, and for all the dispensing to be done for the hospital patients, inpatients, and outpatients. So, but when I became a clinical pharmacist in Maryborough and Harvey Bay, it was more about going to the ward level work. And here, it was to be very challenging, and it was fun to learn a lot of, like, every day. Myself and my partner, we both looked after like 2 wards each, and we have to go after the doctors finish the rounds. We had to go, and we have something called National Inpatient Medication Chart. In that, we do have space for pharmacist comments. So we look at the patient's case notes. We look at what's going on, what sort of condition they have been admitted for, whether it's a surgery or a cardiac arrest or like an MI, or or they have any other issues like epilepsy, or it could be fistula, anything for that matter. And we did. So we looked at case notes. We looked at the progress notes. So every first thing is, if it's a new patient, our profile was more into doing a medication reconciliation. So we need to interview that patient, look at like what they were taking at home. There was a specific chart for that. It's called a MAP form, a medication action plan form. So here we record all the medicines for the patient from either, we have to have two resources at least. So either their doctor or their retail pharmacy where they normally get the medications, or previous hospital admissions. So it's mostly the present scenario. Most probably what we used to do is get in touch with their retail pharmacy or community pharmacy, where we used to get that information. They used to fax it through in those days. Then we have to write it down. Or even more important thing is, we used to talk to the patients as to understand how much they have an understanding of what medications they are taking, why they are taking it, and do they really understand why they're taking it. So all those aspects. So first point of contact when you talk to them is their interview. If the patient is not able to answer, it could be because a patient is basically having a drowsy episodes, or it could be because they are like mentally unstable to talk about their medications, or they don't even remember, just in case of senile dementia cases, Alzheimer's cases. In those cases, we used to get their information from their retail pharmacy or their doctor, or the even next of kin for that matter, because the next of kin generally tend to have a good information about the medicines if they are caring about them. So once we know their medications, what we used to do is we check if the doctor has written any medications for them in the chart, and we used to reconcile it. The reconcile means that most of you guys would know about it if you're working in a hospital. That whether the doctor is continuing that medication for that specific patient, or whether they have changed anything. It could be dose, or it could have been they would have seized the medication for that for the patient, because the BP, if they are on a BP, say for example, if they are on a BP medication, they could have seized it because the BP is already low, or if they would have changed the agent because the BP is high, or if the blood sugar is high, they would have changed that agent, or they would have put two medications for them. So we need to look at it, and we used to record it in the map form. And if there's any change, we used to ask like why it has been stopped. But first, we look up at the case notes. We understand what's the parameters are, like normal parameters like BP or anything. Sugar and all the information. And then if there's any change like we thought was not correct, we used to write it up and speak up to the doctor about that. And we used to understand why there's a change in the medication or change in the dose, or they have been seized. If that's the case, we used to write it down or note it down in the case notes that this has been changed or this has been seized. So that was a part one job of a clinical pharmacist, which is medication reconciliation. Once that's done, we have to monitor the patient every day if there's any change in their medications or if there's any change in the lab parameters. So as a clinical pharmacist, we used to look at the lab parameters for example, if it's like blood sugar, or if it's like an infection case, if there's a WBC has increased or a CRP has increased, a lot of lab parameters. And, based on what sort of conditions they are involved, it could be on any other enzymes, liver enzymes, if it's hepatitis or jaundice, or if there's a renal issue, we need to check for the creatinine clearance or the GFR and all those aspects. We need to calculate it. And then based on that, we need to make the decision. So if the renal condition is not good and the drugs which has been prescribed are cleared through the renal pathway, we have to determine if the dose is correct, and if the dose is high, we need to intervene and speak to the doctor, or write up a note in the doctor's case note, like in the case notes, saying that please do consider changing the dose because the renal condition is not apt for that dose. I hope it's audible for everyone. Yeah.
Yes, sir.
Yeah. Okay. Good. So so that's the next routine we had, and after once the pharmacist looks at everyday cases, for in a setup like Australia or UK, where NHS, where the government looks after the the patients, the main priority for the doctors and nurses is to make the beds empty for the next incoming patients. So our main issues were like how to get the patient going up and going, and so that they can be discharged as soon as possible. So as clinical pharmacists, we used to speak with other healthcare teams like physiotherapists, occupational therapists, and nurses. So every week we have a meeting with the doctors, nurses, and in a conference room, and we discuss the patients' cases as to when they're going to get discharged, and what are the issues we as pharmacists have specific to their drugs, or the way they're using it, or their inability to use it, or even like nurses tell about the inconsistency they have in terms of their administration methods, or like they feel that this person will not be capable enough when they go home to take the medication. So based on all those scenarios, we still work it out and then see if the patient needs to be discharged or he still needs to be hospitalized. So we had patients who were literally living in the hospital. I had one guy who was like really bedridden, and he was there for like nearly 1.5 years in the hospital because the government bared the expense. It's free for the citizens there, but it will be a different case in India if it's that long. And we had some people even like come in and they go home, but on the same day or the day surgery, or they even stay back for like 3 or 4 days or 1 week or maximum 1 month up to the max, and then they get discharged. So this was this is while the patient was an inpatient, and we look after those aspects. But even while when they're getting discharged, we had another duty to do. What we did was we did a discharge medication reconciliation. So say for example, they came for a high blood pressure, or or even like a high blood sugar level. So they had an infection there, and the person is diabetic. So infection is cured with an IV antibiotics, and they're back to normal. And then when they're going home, we need to check the previous records, which is using the MAP form, to see if the patient is back to normal and he was taking these diabetic medications when they were at home, or with their GP's medications. So we need to reconcile that and ask our doctor to either write the same, or if he feels that that's not really necessary or he needs to change it, he changes that, and we prepare a new discharge medication profile. And we dispense, or we give that list to the hospital dispensary pharmacist down in the pharmacy. And or even sometimes if he's not there, we have to do it on our own, like prepare everything, label it, and dispense it, label it, and then pack it up and put it in a bag. And we prepare the medication profile for the patient as well. So medication profile, and that clearly tells about what medication they're using, the generic name, the brand name, why they're using it, like in what condition they're using it, how to take it, morning, afternoon, evening, and night, and if there's any special directions required for that medication. It becomes very important for the clinical pharmacist when the patient is like getting discharged, especially on a warfarin. or any blood thinner or any cardiac medication, we need to give extensive counseling on them, because as you are aware as Pharm graduates, that it has a very low therapeutic index, and they need to be wary of what they're eating, what sort of medicines they're taking, if there's any drug interactions, and all those aspects. So that's the discharge work. So apart from that, as clinical pharmacists, we had to take sessions for nurses, or sometimes even junior doctors, the MBBS interns, that we talk about condition and how to manage those conditions in terms of deeply going into the pharmacotherapeutics aspect of the management. So so that new interns from medicine or nurses wouldn't have that much knowledge as pharmacists in terms of the nitty-gritty of the medicines which are consumed in management of the condition. So we do give in-service or presentations to the nurses, or even in houses, what do you call as residents, house surgeons, what do you call it in India. So we used to give that presentation to them. So that was the profile we had as a clinical pharmacist in my career. Then after that, I moved into the space of health informatics or pharmacy informatics. As I said earlier, that I had a passion for that as well. So I did come back to India for that time, because at that point of time they said you don't have a local IT experience. So I came back to India in 2012 and worked for a company in Pune, Home Healthcare Solutions, and I was an implementation lead in the pharmacy informatics space. So I used to look after all the development of pharmacy software aspects for a hospital, and even requirement analysis and developing the software. The coders used to do it, so we need to explain them in a way they understand, the engineers understand. So it's more about flowcharts, and easy way for them to understand how this functionality happens in the software. So as I had a subject matter expertise knowledge for working in Australia for many years, so I was able to explain it to the software engineers, like how to do that. And when they prepared it, we used to do the testing on my side. And then we had a group, other pharmacists who were working under me, who did testing of the software, how it was working. So we had clients in Delhi, in other countries. Yeah, we had one in the United States, and then we had one in the Middle East. And so I was there for like nearly 1.5 years. Then we moved to Hyderabad, and because I bought a house here. So then here I worked for Deloitte as a consultant for nearly a year. And then I moved, work pressure was hectic, and said, okay, we need to have a work-life balance. And I moved back to Australia, and I wanted to work there in Western environment. And moving back to Brisbane and Queensland, I did get a job as a senior application specialist or senior consultant with the Queensland Health, which is the government office of eHealth. And there we implemented electronic medications management in big hospitals like Prince Alexandra. It's one of the biggest multi-speciality hospital in Queensland, in Brisbane. It's a 750-bedded hospital. So I was involved. That was the first site I was involved in terms of deploying an electronic medication management software integrated with the EHR, electronic health record. So my job was to prepare the documentation work for the doctors and nurses, how to use it, and to coordinate with the Cerner Corporation, which is the company which had taken the contract with Queensland Health. It's a very multi-million-dollar contract, and to talk to software company and to my counterparts in my office, and also with during deployment, after deployment, I used to talk with the nurses and doctors and resolve the issues. If there was anything not working in the software, we had a build which I had access to. That was my job as a senior application specialist for Queensland Health in Brisbane. So after that, we had to move back for family reasons to India, and now I'm here and back to Hyderabad. My previous company did offer me jobs, but I plan to implement the knowledge and experience we have as pharmacists, retail pharmacists, and hospital pharmacists and clinical pharmacists back in Australia to the Indian scenario Indian scenario in a community pharmacy setup. So here I am. We have started MyDocs Pharmacy, and what we do in MyDocs Pharmacy, we have a lot of that information in our website, which is mydocspharmacy.com, and we're also on Facebook, which is Facebook and MyDocs Pharmacy. What we do here is personalized labeling, and we do have ancillary labels or cautionary labels, which is actually attached to each label, and this is only for people who get prescriptions, and also people who have electronic prescriptions, physical and electronic prescriptions. And we do counsel our customers very well on about why they're using it. We need to use motivational interviewing technique. Probably some of you would have attended my sessions before in other colleges where I did in the international guest lectures. So I talk about motivational interviewing, which is basically you ask about the customer. So yeah. Now, I have finished my part of the way MyDocs was open. Now we'll go to the second part, which is what we are doing here and how we can change do a paradigm shift in the practice of pharmacy in India. So what we do here in MyDocs Pharmacy is, as I said, we do personalized labeling. It comes up with a customer's name, the doctor who has prescribed it, which you can see these aspects in my website. It talks about the label has on the top. We have a caution saying that it should be kept away from the children because, as you know, medicines are not good for children if they take it by mistake. And then we have the generic name of the product, and then we have the brand names in the bracket. And below that, we have the expiry batch number. Batch number, why do we have? Of course, the bills do have it. In India, like if you go to Apollo or MedPlus, the bills do have the batch number. But if you label it with the batch number and the customer keeps that carton with the label at home, if there's a recall from the government side or from the company side, which is very unlikely, but it can happen. And many of you would have been aware recently that we had a recall of ranitidine because there was a issue with NDMA or NMDA. Sorry, I don't remember that. It's mixed up with the medication, and that was a cancer-causing agent. So there was a big recall of ranitidine. I don't know how many retail pharmacies did inform to their customers, or it was just more information from Google News. So we have in our software in MyDocs Pharmacy to track out the patients with the batch numbers and the medication they were taking, so that we can inform them that they need to stop the medication or throw it away or dispose it. And also we do have the expiry date. So in India, we do cut the strips. So Western countries, it's not the case where it's given as a whole box. So everyone has a whole box with them. Even if they want like 10 tablets, they need to buy the whole box. That's the way, because the government funds the medication for them. Whereas here, people have to spend from their pockets. So here we have an expiry date on the label so that it's even if it's cut, it's easy for them to understand that it's not going to get expired so soon, and especially if it's an expensive medication. And also it has the price of the product, which is even there in the Western countries. And we have the instructions. The doctor writes the instructions here. Some people do understand it, some people don't, because the handwriting may not be legible. So in that case, it's very cleanly printed on the label with plain English, like how to use it. And then we have the customer's name, the doctor's name, the pharmacist who has dispensed it, pharmacist's name, the pharmacy's name, the phone number, and a website address, which is slightly modified from the way I have portrayed in the website. So that's labeling. Then we have cautionary labels. What happens here is, say for example, if the person is taking on a benzodiazepine, the doctor has given alprazolam or diazepam. So the chances that we know that it's going to cause drowsiness, and that the person wouldn't know. But if he goes to any other pharmacy, they won't be able to explain it, because unfortunately we don't have many pharmacists working in the pharmacies. But like we put that cautionary label saying that this medication may cause drowsiness, so do not drive or operate any machinery, and that sort of information as a cautionary label. We also have cautionary labels for many drugs, like for example, metronidazole, do not drink alcohol, as you know, it causes a disulfiram-like reaction. Or if you have something to be taken once a week, we put them like take it once a week, or if it's a suspension, shake it very well after use, and that sort of thing. It goes like that. And apart from putting the label through and the cautionary labels, we counsel them on many aspects. So understanding the practical aspects while practicing here, what I could figure out is that people don't open up. They don't talk to you. And they feel that you're just another pharmacy, and just a normal, non-pharmacy person working there, and they just put it in a bag and give it to you. But when we label it, then we give a counseling. First thing I ask them is, what did the doctor tell you about this medicine? If he has prescribed, did he tell you how to take it, when to take it, and what are the common side effects? So that's a motivational interviewing technique. So once you ask these questions, they open up to you. Think, oh yeah, doctor told this, but he didn't tell this. He didn't talk about any side effects. He didn't say how to take it, how to use it, how to, say for example, a puffer, or say an asthmatic patient, they use a puffer. So did the doctor show you? No, he didn't show you. Did the other pharmacy show you? No, they didn't show us. So we show them how to use it, how to use a puffer, and what happens like after you use it. You need to rinse your mouth, especially if you have a steroid in it, because it can cause fungal infections in the mouth and sore or hoarse voice due to steroids available in the puffer. So that's one of the things. So in India, we have three situations, as everyone is aware. Point number one, people come out without any prescription, they ask for medicines. Then point number two, we have people who just write it down on a piece of paper, which is like just a rough paper. Or even they show up in a WhatsApp message saying that, oh yes, I have these two medications, can you give it to me? And third one is like, you have proper prescription from a doctor, which has instructions, doctor's name and everything. Even like a miniature diagnosis and vitals of the customer. So for people who come without any prescription, we as pharmacists, what we do in MyDocs is ask them, why do you need, what sort of condition? We need to diagnose it, but it doesn't mean you diagnose a complex condition. If it's just cold, cough, and fever, smaller things, we can easily talk to them and understand them why they need this what sort of condition it is, and what sort of problem they're facing it. Based on that, we take a decision. And for that to happen, we need to have an understanding of the pharmacotherapeutics of from head till toe. You need to know all the condition, all the disease condition. Not talking about very complex things like cancer or in a community space. I'm talking about a community or retail pharmacy space. Just to understand, like from head, you need to know what is the dandruff, what causes it, what are the treatment protocols for that. Then you come to face, just I'm talking about giving examples. Like you can go about if they have acne, if they have melasma, which is like darker spots on the face, or if they have a blocked nose, or if it's an eye condition, you need to understand bacterial conjunctivitis. What happens in a bacterial conjunctivitis? What happens in an allergic conjunctivitis? What happens in a viral conjunctivitis? So you have to have a differential diagnosis. Like bacterial conjunctivitis, you have the pus forming in the eyes. But if it's allergic conjunctivitis, it's just itchiness and redness, and viral does the same. And if you have anything else like a blepharitis or a stine, how to differentiate that, and what sort of simple treatments you can give, home remedies at the same time. What are the simple medicines that is available, like a chloramphenicol eye ointment, or it can be of course, as you understand, like we can't prescribe, but we can't diagnose many things. We have our own responsibilities and reservations, and in terms of how much we need to diagnose. So that's we need to understand our scope of practice. So we look at that aspect. So I can tell you about a case study yesterday where a poor person came to me. He is a local washman here, and then he thinks that we are like a doctor, and he is a patient with congestive heart failure and cardiomyopathy and megaly, and he's on digoxin, and he had episodes of syncope in the day before yesterday. So I measured up the BP, and his BP was high. It's what was like 167 by 120, and that's the reason he's getting syncope. So he said, "Why don't you give me medicines for blood pressure?" I said, "No, that's not under my scope of practice. What I could do is ask you to reduce the salt intake and then do a good walking. But because you have a condition where your heart is enlarged, you need to go and see your doctor. He needs to prescribe it." So as pharmacists, we need to understand our scope of practice and limitations. That's very important. And we need to also, if it's just like a cold and cough, like for example, a simple thing like people come with for nasal drops, right? In nasal drops, of course, you need to tell them use it for 4 days. After that, give a gap for 1 day, or because the chances of rebound congestion is important, is a very important aspect to be known, because it can cause more blockage. And so simple things like that. Then we also talk about prevention methodologies to people. So how to prevent this condition, how to help them out to overcome this problem in the near future. So you may think this aspect is very important. We feel that okay, we are trying to give them prevention measures. So will this guy come back? So in terms of business perspective, please don't think like that. The more you help with your knowledge, and more you help the people with your getting them rid of the medication, they will surely come back to you. Because if you look at the opportunity we have in India, is that we have so much of population. We don't have proper pharmacists who are trained very well in pharmacotherapeutics and have an understanding of the disease condition and rationalize the treatment for any customer. So if you have that knowledge and you treat a customer, so they are bound to get cured. And once they get cured, they are your repeat customers. And once they become your repeat customers, they become your ambassadors. And I could feel that in my area. Well, you can see there are a couple of Google reviews. Yeah, so there were a couple of Google reviews in our area, but there are not many reviews going on. But I can see from the way people speak around, they refer everyone to our pharmacy. I'm not boasting about it, but I'm just telling you the fact. And so the reason is we even today morning when one of the family graduate came up to our pharmacy to look up as to how we practice, we did explain the same thing. You try to reach the people, you help them out, get rid of that the problem, health problem. Also, you tell them prevention strategies. That really helps. The reason is they feel they trust you. When they trust you, they refer other people to you, and your name goes bigger. People reach you for more information, and they feel that you're more a trusted person, and that's how your business grows. So imagine the number of people we have in this country, just in case, even Hyderabad. Even if you have 10 pharmacies around, the people will surely go back to a place where their person has knowledge, and they come back to you, they refer other people. So please do remember that, and that if you're going to practice in a retail pharmacy environment. It has come to that level to some, I can say, when I have Pharm graduates who are working in pharmaceutical companies very near Pragati Nagar and Nizamabad. As you know, Bachpally is full of all big Dr. Reddy's lab, Aurobindo. Here, people, even though they are Pharm graduates, they work in industry, so they don't have the latest pharmaceutical knowledge in terms of treatment protocols or patient care. So they do come and ask me or even my wife, then, has the doctor prescribed the medicine correctly? Has he given the right dose? So that kind of trust we develop when you do a proper counseling for the customers. So So apart from that, what we do in MyDocs is we give them a medication profile, and which basically talks about what we did in Australia, like it's which is their generic name, the brand name, what it's given for, how in layman language, how to take it, like morning, afternoon, evening, night, and if there's any special directions. And we are also going to come up with those health system in the near future once we have a bigger clientele. And so that helps with sealing up the medicines in a Webster pack, and they can take it wherever they go by cutting like one day's supply, or if they have multiple, like more than 3 or 4 medications every day, or 3 times a day or 2 times a day, and they can take it up. Especially it's good for elderly people who have senile dementia, who tend to forget the medicines, and also helps their children to manage it well. And even if if you have parents who are abroad and the parents live alone here, it's easy for them. So those who live in US or any Western developed nations, they really appreciate that, and it would be really helpful for them. And they also appreciate the way we label it, and we talk about the side effects and common side effects for which they should not be worried about. Say, for example, if the patient is on nitrofurantoin, so the urine may turn into brown color. Did the doctor tell you about that? The patient said no. Well, I said, yeah, this will happen, but don't worry about it. And you know what the feedback was? Next day, his cousin sister came up and said, you're doing a great job. You're doing a wonderful job. Nobody explained these things to us. And, I'm not saying doctors don't do, but, they are busy as well. So they may be busy with patients, or they tend to forget things, or they may or may not have the knowledge of talking about this highly, detailed aspect of any medicine's side effects or the way it should be administered or used. So what I'm saying is basically with MyDocs, this is what we are implementing to do things here in India. So changing the way pharmacy needs to be practiced in a very professional way, and you become the experts in medicines. And even I had an interaction with a dentist the other day, and she has seen our labels because dentists tend to write a lot of amoxicillin, clavulanate, metronidazole, and all those medicines, painkillers. So I do explain about when we label it through, when she sends the prescription, like for metronidazole, you should not drink alcohol, and we tell them about like it may cause a metallic taste in the tongue, and sometimes a headache as well. So when the customer goes to them and says, "Oh, this is what they said," and when I met her for the first time after nearly 6 months when we opened the shop, she really was glad to meet us, and she said, "We need people like you. We want the change in this profession in India." So that's what we like, and that motivates us to do more in the society. So yeah, this is all about MyDocs we have here, like and we are still in the almost in the finishing up stage with our software because I was involved in the design and development of that, and we still have glitches and we're rectifying that, and we're almost closing the project. So almost and in probably in a month or two. Yeah, we'll be full fledged, and even I was like, we opened in the hot time of Corona when it's like mid of April and end of April, and so right now we didn't expect anything, but now that it's almost over, and still is, let's say we need to do the safety precautions with Corona, but at least people are moving about in and about, and we the reach to the people is better, so we feel. There may be more people dropping in, the footfall may be higher, and they will understand the way we practice as compared to other pharmacies around. And once that happens, if I get busier, I have plans to take up interns who are keenly interested or passionate about community pharmacy, either to work or if they have plans to even open their own store. We are looking forward to franchisee operations in the near future. So for that to happen, they need to get trained under us, like for about nearly at least 3 to 6 months to understand what we are doing in terms of therapeutics, in terms of customer service, in terms of counseling and all those aspects. And once they have an idea, either they can open up a franchisee or you can, work under us if we're going to expand to the next store. Talking about online pharmacy, that's everyone feels that's a big competition, but I feel online pharmacy is okay if you have a chronic medication, but even that it should be labeled and properly. If it's like a new medication, online pharmacy doesn't really help, and it may be helpful if you have a proper, highly qualified pharmacist who has a good understanding, talk to the customer about that, even like when they're starting it. But that's highly unlikely right now in the situation we have here. So yeah, so still the store-based concept is good, but as I said, we as PharmD graduate, or you as PharmD graduates, or even you as a pharmacist with a good amount of pharmacotherapeutic knowledge can make the difference in this country, and we can look forward. It's a very big market. I'm telling you, it's a very big market, pharmacy, but it's managed by non-pharmacy players a lot, and which should not be the case because you're basically dealing with the life of a customer or a patient. And so I believe we, with so much of knowledge and still more to learning every day, and we can make a difference in the society. And of course, you earn a better living when you have your own business, or even if you you have that mental and the satisfaction that we have used our knowledge in a person's service. So it's almost just 10 minutes to 7 o'clock. I believe I had a good session, and I've given you the insights of what we do here in MyDocs and my journey from scratch to MyDocs. I'm happy to take any questions if you have. Thank you very much.
Good evening, sir. Myself Satyasree. Uh, Sir, I have a question. To what extent your knowledge in health informatics helped you to grow as a clinical pharmacist in Australia?
Oh, no. Health informatics is totally different from clinical pharmacy. Clinical pharmacy is more about medicines and the patient's health and management of disease conditions. Health informatics is deploying the knowledge you have in clinical pharmacy and hospital operations into the software space. Does it answer you?
Yes, sir. Thank you.
Okay.
Hi, sir. Good evening, sir. This is Arun from Hyderabad.
Yes.
So, what are the challenges do you face while delivering the service to a particular patient? And if they come with only the strip which they are taking previously,
Mm-hmm.
they will ask the only that type, that brand of medication and
Mm-hmm.
similar strip they used to have. But
Correct.
we can have that. Don't have that in our pharmacy. How can we overcome that challenges?
Good question, Arun. So that I face it every day, especially it happens with the people who are educated and even who are not educated. So it happens because the firm reason being they stick on to what the doctors say, and I don't blame them because when they go out, we have non-pharmacists working in the pharmacies. They tend to give something else, so which the doctor may object to, or if it's a different medication, or it could be a different way altogether, like a deal medicine. So what we tend to do in that situation is that we tell them that if they are educated people, we show them this is the generic name, and this is the how many milligrams or percentage it is, and this is what the brand name is. And if we have this medic, we don't have this brand. One thing is, if it's urgent, you can take this other brand if you're happy with it. If you're not happy with it, like if you can wait for it, we can procure it for tomorrow. If not, they have to go and see other pharmacies.
Yes.
So we tell them, Arun, but thing is, some people are happy to take because we have a lot of generic shops now, and they're able to understand that yes, it's just a medicine. Brand is even you can keep as a AK 500 milligrams, and they tend to take it. But some people are very persistent that I need just the same medicine. We say we're sorry, but once they understand that what we're doing here is correct, like even the uneducated and educated people, because they know that when we talk to them about side effects and counseling points and prevention strategies, they feel they have a trust. They say, okay, you give me, if you know better than us, and you give that same medication.
Okay. Thank you, sir. It's covered.
Good evening, sir.
Yeah, good evening.
Sir, I have a question, sir. During
Uh-huh.
this COVID crisis,
Mm-hmm.
it is difficult to have direct communication with the parent herself. Sorry, patient herself. So, how
Uh-huh.
do we counsel them, sir?
Uh, Look, we still have that board saying that we need to wear a mask when they come in, and we maintain a certain amount of social distance with the customer, and some people were reluctant to even come in, and we maintain at least a distance of 3 feet, and we talk to them to about the medication, counsel them, and we just label it and give it to them in a bag.
Thank you, sir.
Mhm.
Hello, sir. Good evening.
Good
Sir,
evening.
what steps do you take to remain up to date on new medications, sir, or any
Okay,
researches?
right. Look, in terms of a community practice right now, um, we do have a reference like online. As you know, everyone knows there are a lot of options for you to look up the latest treatment protocols. I do refer a lot of Australian sites and even American sites. And if there's any protocol in India, we do refer that. But this question is very much pertains to a hospital scenario where you have different protocols for managing a disease condition. But when it comes to a community pharmacy practice, you will find more of a case related to common cold, and of course you do find complex cases as well. In those cases, we do check it up, like what is this online, what is the current status. If not, we know the standard treatment protocols for them.
Okay, thank you.
You're welcome.
Hello, sir. Good evening. This is Uday.
Hi,
I think
Uday.
you might. How are you, sir?
I'm good. I'm good.
Sir, okay. Thank you, sir, for your wonderful session.
Mhm.
I made a personal visit to your pharmacy once. So I noticed that you are functioning in a very unique way of retail pharmacy.
Mhm.
Apart from that, you not only fill prescriptions, but also educate patients about their medications and possible side effects, which is really a unique approach, sir. Sir,
Mhm.
I do have a question.
Mhm.
How do you address if the patient come looking for OTC medications with chronic comorbids?
Okay. Good question, Uday. So we do ask them about comorbidities, very specific to the medicine what we are giving. For example, if the person is coming for a pain relief medication, so they say I have blood pressure issues. Then that as pharmacists we know that all the medicines, NSAIDs, tends to increase the blood pressure due to sodium retention. So if it's a very, very high blood pressure, then ask them, are you in control or is it bad? If it's really bad, we tend to give them just paracetamol to relief, and then ask them go and see a doctor if it's really bad. But if it's not like assess your blood, we assess the blood pressure. If it's like under control, we still give 2 or 3 doses of NSAID, which is recommended for that sort of condition. This is one example.
Thank you, sir.
You're welcome.
So I can say that MyDocs pharmacy doesn't order a patient, but they show affection towards the patient. I have seen an incident in all pharmacies. They paste no mask, no medicines. But in MyDocs pharmacy, I have seen if please wear a mask so that COVID precautions like that. Some message is given with affection. So that's a good sign, sir.
We need, as Uday mentioned, generally we're not supposed to be very upfront and rude with the customer, saying that no mask, no medicines. I've seen it in many pharmacy. I feel like even customer feels like they're basically trying to avoid me if I don't have a mask. Which is in a way safety for both of them, but it should be put it in a polite way. Thanks, Uday.
Thank you, sir.
Anyone else has questions?
So Alvin, actually, you can stop streaming on YouTube now. Hi, sorry.
Okay.
So I joined a little late.
Thanks.
I was traveling, and